About registration coming out. And the early one, Dr. Amol. Wrong name, we'll go to the next one. Okay. We'll go on to the next session by Dr. Niranjan Agarwal, sir. Dr. Niranjan Agarwal is a consultant laparoscopic and colorectal surgeon, Bombay Hospital, Wakad Hospital, and Salasar Nursing Home. He is the assistant professor in the Department of General Surgery, Bombay Hospital Institute of Medical Sciences. He is the president of the Association of Colorectal Surgeon of India, executive board member of International Society of University of Colorectal Surgeons, and vice president of the Federation of AMC India, chairman of network of AMC Hospital. He has got many publications and he has authored so many books. Over to Dr. Niranjan Agarwal, sir.
Thank you, Maya. Thank you, IMA, at the very beginning for giving me this opportunity, and a very warm morning to all my fellow
Excuse
colleagues.
Me, Niranjan, I request all those who are sitting in the front and especially here near this counter, please keep silence. It is disturbing the speakers. Your volume is very high, please.
Thank you, Chairperson, for voicing my concern. I was about to say I have an obsessive compulsive disorder as far as when I'm talking and others are speaking in front. So I would request those who don't want to listen, please do not listen, but don't disturb others who want to listen, or at least not the speaker also. So keeping it brief because we have got time restraints. Anorectal disorders, friends, we all know something like pile, fissures, fistulas are so common in our daily practice that for us, when you write, it's a bread and butter for us, pile, fissure, fistula for a surgeon, like urine and stool are bread and butter for the pathologist. Piles and fissures or anorectomy is bread and butter for the general surgeons. However, most of disorders are first seen by the general practitioners who, because of lack of infrastructure in his clinic, only evaluates them on history. And therefore, everything and anything which is related to the perineum goes as piles, you know. Any pain is piles, bleeding is piles, something boil is piles, everything comes bile. And that is not true. We all know that there could be so many other disorders, not only piles or not only fissures or fistula, they can be even cancer which can present as piles. So a timely evaluation may cause some serious delays to be avoided and therefore save much life. So today I'm going to talk to you about the recent updates, some of them, or take you through a journey of these few common disorders. Coming to the piles, apart from the definition which you should know, you should also know, which is more important, is that 50% of the population above the age of 50, like most 50% sitting here, I would say, will all develop piles sometime or the other in their lifetime. And it will equally affect both males and females. And they do have a tendency to run in families. And if a patient with below 20 years come to you saying there is bleeding pile, don't take it as piles because they are rare below 20 years. The theory of formations, not to go into detail because more of a surgical this thing, but just to enumerate, there is a sliding, because you need to understand the treatment which I'm going to tell will be based upon the theory of the formation. That is one, sliding anal cushion, then there is a failure of the intrinsic vascular mechanism, though there is hypervascularization, and there is rectal mucosa redundancy over there. This which we always talk in our practice there, because you are pregnant or your age, you piles, they are not actually the cause. They are only a precipitating factors like chronic constipation, straining, spending more time in towel, pregnancy, hereditary. They are all precipitating factors. They are not the cause. The types of hemorrhoids, we have got mainly 3 hemorrhoids. There is something called external hemorrhoid, which is seen outside and therefore they are painful because they are covered by skin. Then there's something inside, which is called an internal hemorrhoid. They are covered by mucous membrane. They only can prolapse. Therefore, they are not painful. And then there are mixed both external and internal hemorrhoid. You can see the pictures which I have put across along with the diagrams. And then there are grades of hemorrhoid. Grades means the severity. You can call 1, 2, 3, and 4. And this is my paper which we had project an additional suffix to that A, B, C, D, depending, because in your practice, you must have seen that not all the 3 piles which we commonly call are of the same grade. They may vary. So depending, if it is 1 pile, then it is A, it is more than 50%, then C, less than 50%, B. And this is what me and my colleagues had devised and published. And that is the Indian classification, which is now being quoted across the world so often. And regarding the grade 1 is one which is always inside, 2 is one which comes out but goes in spontaneously, third is one which the patient has to push it back inside after the defecation, and the fourth one being which is always remaining outside. Symptom wise, mainly we all consider that pain should be a symptom, but it is not so. The four ladies on the fourth row should stop talking, please. Bleeding, this is what happens, the flow gets stopped. Sorry for that. So the main symptom is bleeding in hemorrhoids. There is a splash on the pan which is of fresh blood, and the quantity is small. It is usually after defecation, and if you continue to sit over there, the patient will keep bleeding. But if you get up immediately when the sphincter contracts, the bleeding will seem to have stopped. The second most common symptom is something coming out. The patient will say, or you ask them whether during defecation the mass comes out, they will say yes. And if they say it goes up when they finishes defecation, that means it is grade 2, as I said. And if they have to push it back, they say then it is grade 3. If it is remain outside, then again grade 4. Sometimes they get itching because of the prolapse. There is a lot of mucus discharge which may cause soiling and itching over there. And anemia, of course, if there is a chronic blood loss in this patient. Pain, remember friend, is not a symptom of piles unless and until they are complicated. If there is a complication like I'll tell you the number, gangrene or prolapse or thrombosis, patient will not have pain. So if a patient complains of pain and bleeding, you must consider something else, that may be fissure or something. We will come to that. So pain only occur if it complicates. You require to do a proctoscopy to confirm your diagnosis. If you don't have the facility at your place, you must refer it to a surgeon who can do it for you and send back. And when do this patient mandates a colonoscopy or a sigmoidoscopy is very specific, because you don't want to miss a carcinoma in this kind of a patient. So anybody age above 45, those who have got weight loss, history of altered bowel habits, or history of positive family history, are all those patients who mandates a pre-operative sigmoidoscopy or a colonoscopy to rule out some serious disorders. So these are the complications like thrombosis, severe bleeding, strangulations, ulcerations, which may cause pain in this kind of patients. And as I said, it is not, bleeding is not only hemorrhoids. They can occur in fissures, they can occur in polyps, they can occur in carcinomas, so forth and so forth. How do you manage hemorrhoids? So the main aim is to relieve the symptoms and prevent recurrences. The whole therapy ranges either from a conservative treatment landing up to surgery, but none is perfect. It all depends upon the grades of the hemorrhoid, and each one has got its advantages and disadvantages. So for the first and second grade, which are the smaller hemorrhoid, lifestyle modification, because this is a lifestyle disease. It's a problem we have got because of our erect posture, and mainly in the urban areas you get more of this. So you need to correct this lifestyle, and it is true for all the anorectal disorders, to be very honest, not only for grade 1 and 2. And if you don't follow this, then the recurrence rates are very high. Then there are pharmacological agents which are present, which I will talk about. Third is a definitive treatment for grade 1 and 2, that is the office procedure. We can call either banding or sclerotherapy, or you use an IRC machine or a DG Hall machine. And slightly advanced can go for laser, radiofrequency ablation, etc. What do you mean by lifestyle modifications? So as I said, required in all hemorrhoids, reduces recurrences. The most important thing is to have a soft bulk stools without straining, and this can be achieved by a high fiber diet or replacement of high fiber diet by bulk forming a laxative, that is isabgola, to the 20 to 35 gram per day. But only isabgol or only high fiber diet doesn't help. It is only going to make your stool more harder. So you are supposed to supplement equal amount of fluid. And how much fluid you should give? 1 liter per 20 kg body weight. So in an average of 60, you need to have at least 3 liters of fluid. But mind you, again, your cardiac and your renal functions should be within your normal limits. So your cardiologist or physician should permit you to take that much fluid. Apart from this, to avoid fatty and spicy foods, laxatives to relieve constipations. And most important nowadays, as earlier people used to take their newspaper into the toilet, now they take their WhatsApp. The first thing you get up, you first see what is the time in the phone, and the second thing, किसने क्या मैसेज भेजा है रात भर में, एंड वो प्रेशर आ जाता है तो लेकर के टॉयलेट में जाते हैं और फिर पूरा रात भर का देखना रहता है सबको और बैठे रहते हैं, स्ट्रेन करते रहते हैं. So that should be avoided. Coming to the pharmacological agents, there are very popular ointments such as Pilex and Smooth and everything Innovate, and we use it left, right, and center for everything and anything in relation to the perineum. But it's not true. They are only symptomatic relief for a short period. They are not curative. At the most, in the long run, they may cause more harm because there is skin sensitization, especially the steroid-containing cream. And if this patient happens to undergo surgery, you can see that picture over there. The wound is very difficult to heal after surgery in such kind of patient. So it should be avoided for the long term. Among the tablets which are available now, the micronized purified flavonoid fractions are supposed to be the most effective, and the dose is not, you can't give 500 milligram BD, OD or something which you normally see. The actual dose is 1 gram 3 times in a day for the first 4 days, followed by 1 gram twice a day for the next 3 days, and 1 daily for the next 3 weeks minimum, or as you may consider necessary. They act by reducing the venous tone and reducing the venous stasis and increasing the capillary permeability. That is the only evidence as far as the other products which are there, Euphoria, Prostata, calcium, double slate, they do not have very robust data to support their use. In fact, you can use micronized purified flavonoid fractions for immediately after surgery also, because that reduces congestion and edema, and therefore pain and bleeding to some extent are also supposed to be reduced. So when do you use MPFS? That is one in the early grade, that is grade 1 and 2, or pregnancy, patients with pregnancy in any grade, or patients with hemorrhoids with IBD, HIV, etc., where you do not want to operate, and in post-hemorrhoidectomy patients. They are unsuitable for external hemorrhoid or irreducible prolapse or strangulated or any complicated hemorrhoid. Coming to the office procedure, as I had named all of them, they all have got a result of around 60 to 80% success rate. That means around 20 to 30% are going to recur. And how do they act? They all cause some kind of vascular obstruction or some kind of fibrosis in that area, and they cannot be used in complicated piles or external hemorrhoids or those with associated disorders such as fissure, fistulas, etc. In grade 3 and 4, unfortunately, surgery remains the only choice, and that is the only option. But fortunately, it is required only in 5 to 10% of the procedure. And what do we have for surgery? Our conventional surgery, we have the stapler hemorrhoidoplasty, we have the Doppler-guided hemorrhoidal artery ligation, and the laser now. So the conventional hemorrhoid, which hemorrhoidectomy or the Milligan-Morgan or what we used to call, that is the open or the closed, whether you have kept the wound open or closed, it depends upon that. Apart from grade 3 and 4, it can also be used in grade 2, which have not responded to the office procedure, or if you have got associated disorders in patients such as fistula, fissure, etc., will require some kind of an open surgery. In those patients, you can use that. Many patients, many doctors, especially in South Bombay, would try to lure you by saying we'll do an harmonic hemorrhoidectomy or a ligation hemorrhoidectomy. Friends, there is just an energy source which is there, which causes less bleeding. But as far as recovery, as far as the recurrences are concerned, there is no advantage in that. So hemorrhoidectomy, let me put it on record. This is a century-old procedure defined by Milligan-Morgan in 1940, coming to nearly a century with the best result even today for especially the higher grades, and the most economical because you don't require any kind of extra instruments. And the only disadvantage, of course, that is the large painful wound and the time to heal and time off to work associated with the complications, which can be either pain, bleeding, urinary retention, constipation, sepsis, to name a few. So this is a small video. I'll just run through it because the first one is how we do it. That is, first take the pedicle stick because that reduces the bleeding to some extent. Now, this is not a malignancy, so don't exercise radically. To exercise whatever is necessary, the hemorrhoidal tissue, because at the end, you are supposed to leave normal bridges between the two cut hemorrhoids, the skin and mucosal bridge, because if you happen to damage the entire skin area over there, they will end up with contracture and there will be anal stenosis in this patient. So you can see we have taken a dumbbell shape. The anorectum is preserved because there is a role of anodum in the human body. You know, it helps in continence. So the more you remove, the more incontinences this kind of patient may develop. They are just 1 minute video, so don't worry about it. So that was the open, and now when you close the wound, it becomes a close or a Ferguson hemorrhoidectomy. But only thing what one has to remember that when you close it, the suture line should not be under tension. The flap should come very easily. Otherwise, the sutures are going to break through. The other video which is started running is the harmonic hemorrhoidectomy, where instead of the cautery, you are using a harmonic scalpel. The next modality which is now available is the PPH, or that is called the procedure prolapsed hemorrhoid, or MIPH as is marketed in India. That is minimal invasive procedure of hemorrhoid, or actually the word is a stapled anopexy or stapled hemorrhoidopexy. It is not hemorrhoidectomy because we don't remove the hemorrhoid in this procedure. It is the prolapsed cushion and the prolapsed mucosa above, which is resected with the help of this stapler instrument, and the whole thing gets reposited back. It is used in grade 3, 4, and sometime in grade 2, where there is a failed office procedure. But most important, when patients have got circumferential hemorrhoids, when we do a hemorrhoidectomy, you'll end up cutting more skin, and then there is chances of more stenosis. Here you don't cut any skin. Your incisions are above into the mucous membrane, and therefore this is the procedure of choice for circumferential hemorrhoids. There's minimal pain. You can get back to work very early. There are no wounds to dress in the post-operative period, and it's a very easy procedure to learn for those who want to learn. There's a small video how it is done. This instrument consists of this circular anal dilator, operating proctoscope, which you insert, and then you take a purse string suture around 2 to 3 centimeter above the dentate line, complete the purse string suture, and then you have to, can I fast forward this? So there's a purse string suture which is taken, but the entire mucosa is supposed to be buried. You cannot leave any mucosa bare. So you have to be very careful, because otherwise that particular portion of the prolapsed cushion will not be taken into the stapler body, and that will lead to either recurrence or bleeding. In fact, this procedure costs lesser operating time also. You can finish this in 10 to 15 minutes once you are trained in this completely. So this is the stapler which is opened, inserted inside, and the purse string tied across it on the shaft. Once you have done this, stapler, these stitches are brought outside through the windows in the stapler body, and the stapler is fired. So this is how it is brought out. Sorry. I think it will not fast forward. The second last modality in hemorrhoid is Doppler guided hemorrhoidal artery ligation, where you ligate the terminal branches of the 6 terminal branches of the superior hemorrhoidal artery ligate, and you need to fix the mucosa above the dentate line. It is used in grade 2 and 3, but 4 it is not a good element, because 4 is mainly a prolapse. It comes out and remain outside. So this takes only care of the devascularization. I said you need to know the theory. So the hypervascularization element is covered, but the prolapse element does not get covered with this. And the last baby on the horizon now is the laser hemorrhoidoplasty, where you use a laser to kind of use energy inside the pile mass to vaporize the whole thing and cause fixation. But the results are only around 60–70%. However, if you add a hemorrhoidal artery ligation with the help of your finger also, you can feel the hemorrhoidal arteries and ligate, then it becomes a hybrid procedure, and the results improves to around 90%. But and the advantage is obviously being no surgical trauma, reduced operating time, significantly lesser pain. When you get this pristine and all, which say no pain, no scar, they're all gimmicks. Actually, can a surgery happen without any scar? It can be a lesser scar, So don't fall prey to all those kind of things. And if it is not used properly, as we always say, a fool with a tool is always a fool, still a fool, So if you overuse the energy, this is what complications one can get and one should avoid. This is a small video of laser. So you redefine the grades of the hemorrhoid on table, palpate the branches of the superior hemorrhoidal artery and ligate them. And once all the branches which you are filling, which you feel or palpate rather, you have ligated them, then you insert the laser probe through the mucocutaneous junction and deliver energy. The amount of, there is no shrinkage on table. Remember that the heat which is released will take its own time. There is a thermal heat and there is a time limit to that where it will start acting and then reduce it. So that's why we even use ice after this procedure. So this is the laser probe which is inserted, and you can see the bright light of laser over there. You insert it on all the major hemorrhoids and burn them and withdraw. That's all. There are no wound. You see nothing coming out now, and this is the ice pack. This is the results. You can see pre-operative such large hemorrhoids but gets reduced in the post-operative period. The benefits, of course, to the patient is it's lesser invasive, lesser bleeding, faster healing, can be done in a daycare. And for the surgeon, it is like you are using the advanced technology, you get a good name, and for the same thing which you have done in an open manner, you get more money. So Brijesh is nodding his hair because laparoscopy earns him a lot of money for the same thing which he can done in open. So again, the hemorrhoids in the special situations such as portal hypertension, actually they are anal varices. They are not hemorrhoids. You need to distinguish with them and treat portal hypertension rather than treating this as hemorrhoid, because that will lead to severe bleeding. In IBD, try and avoid as far as possible because wound healing will be a big problem. And there are many gynecologists over here. I would like to tell them all your piles are going to, most of 80 to 90% of them are going to resolve once the baby is delivered. What you need to go through is to tide over that patient over that crisis. But if the need happens that they are complicated bleeding and it is more than second trimester, you can take our help. We can do this hemorrhoidectomy or laser surgery in a left lateral position in the local anesthesia. So this is again from my paper, grade 1 and 2. We said lifestyle modification, medical treatment, then office procedure followed by surgery, and grade 4 only surgery. Second modality, second disease in common is the anorectal, the anal fistula, where are two phases, acute is an abscess and chronic being a fistula. It all originates as an abscess in the intersphincteric plane where there is an anal gland which gets infected, and the whole thing bursts in various planes and causes a fistula. It is fortunately 95% of them are all because of infection in the anal gland, but then 5% can be either tuberculosis, inflammatory bowel disease, diverticular disease, carcinoma, etc. To classify, just because you should know the treatment modalities which we produce, the age-old classifications of parts like intersphincteric, transsphincteric, suprasphincteric, extrasphincteric is difficult to follow in all the patients. So a simple classification for clinician, whether it's a simple fistula or a complex fistula, makes all the difference. Simple are those with single opening, single track, straight track, no connection with adjacent structures. And even in a female patient, anterior place fistula are not supposed to be simple, even if they look simple, because the musculature out there are quite less. The rest all will fall into the complex, whether they are horseshoe, they are high transsphincteric, or they are extrasphincteric, supralevator, or they are associated with tuberculosis. Even recurrent or an abscess setting, they are all called as fistulas. Clinically, these patients will present with a boil which comes and goes with discharge intermittently. Every 15-20 days, if the patient gives you an history, you don't even need to do a complete examination, but history itself will tell you that it is suggestive of an fistula in ano. The imaging, it's not required in all the patients. Nowadays, I see many fistula patients coming with MRI report to me. Not all patients should undergo an MRI, only complex fistula. Yes, definitely they should go undergo an MRI because that's the gold standard, and never do a fistulography in this patient nowadays because it's more or less obsolete. Nobody does it anymore, and it does not give you any extra advantages. So management, again, depending whether it's an acute presentation abscess or a chronic fistula or a simple or a complex fistula, or it's belonging to the cryptoglandular or a specific disease, your treatment is planned accordingly. The main aim is to identify and eradicate the infected anal gland and preserve the sphincter muscles around that, because if you don't do, a balance has to be stricken, and that is what which troubles most of the best of the surgeons. And whatever techniques are available, none of them are perfect, and none of them, you cannot say something superior to the other. There are various methods for simple, like simple fistulotomy, fistulectomy, and the newer methods such as lift, primary sphincter repair, or laser in this kind of patient. In an abscess setting, the incision and drainage is the, I finished my time? Yes. 5 minutes? Huh?
Already exceeded your time.
If you are kind enough to give me what to say. Okay, thank you so much. I appreciate your kindness. So incision and drainage is simply done, but 40 to 50% of this fissulas will form an abscess will form a fistula. So one can do a primary fistulotomy provided you are trained in doing your in that acute setting, recognizing the internal opening, recognizing the sphincter muscles and doing it. This is how I do it. You aspirate, decompress the abscess, insert methylene blue, identify the internal opening, then you drain first thing the abscess and then curate out the entire fistula and give a adequate drainage. Fissulectomy with sphincter, simple fissulotomy is still the gold standard for a slow fistula, but for complex, doing a fissulectomy is not enough. You need to do something like a sphincter repair for these patients. And the other procedures which are not done, I will not talk much about them. A set-on is a very life-saving procedure for most of the surgeons, I said, not the patient. I say this because there you can be safe with the sphincters. This patient particularly was into septic shock, who referred to Bombay Hospital with an abscess in the vulva, abdominal wall, everything. And you can see what we have done is just tied a small set-on. We realized it's a fistulous abscess, so drained everything and even sutured it back and just kept a set-on over there. In 1.5 months time, you can see the entire thing has healed. Similarly, this patient, I did it at Tanwar. Patient was again abscess in the popliteal fossa, drained outside, sepsis, we realized it's a fistula and then closed it accordingly. The newer surgical options are mainly sphincter sparing and therefore they cause less incontinence, but the recurrence rates are very high. So I do most of in my patient, I do a primary sphincter repair, cut out the entire fistula, remove it and repair the sphincter on table, because that gives the 95 to 98% result with minimum incontinence, and that's also minor. These are small videos which I would not show you. I'll just show you some pictures. So such kind of complex fistula, you can see we remove the entire tract and do the sphincter repair. Again, here you can see recurrent fistulas with 3 opening externally. We have removed and preserved the skin flap and closed it back. Again, here 2 openings, same thing. This is a complex fistula with this patient had colostomy done in Dubai and he had been referred here for waft. After 2 waft, the patient referred. Ultimately, we removed everything and closed it, and the colostomy also got closed. So this is patient with supralevator fistulas. Same thing we do. And this is with multiple openings. You can see we have removed each and every tract and preserved the sphincter. And at 1 or 2 places where you have divided, we have sutured it back. The new technique again is laser. Again, hybrid is better because only laser causes high recurrence rates, and hybrid where you mix laser with either video assisted fistula treatment or lift or low fistulotomy, that gives slightly better results. So here in this patient, young boy, 20-year-old with a fistula in the scrotum and the anterior part, we did a waft, we cleaned out everything and laser ablated the tract, and that healed. Here again, anterior fistula, we did a lift with laser, and here a horseshoe fistula, I did a low fistulotomy, removed the pathology from there, but the other tract we just did a laser ablation. So these are the results which are seen. Again, horseshoe, same thing. Sharsutra, most of you will ask. It's a chemical set-on. Basically, the results are not better, but sometimes you get very severe pain in this kind of patients. So we'll miss this. We'll miss this. Fissure, I will just for the update of the people. This is a chronic fissure. The one was an acute one. The chronic one you can distinguish by the external piles, which you call. It's not an external pile. It's an external skin tag or a sentinel tag, as we call. That is for the chronic fissures, more than 6 weeks. So if you see an external tag, you can very well say, patient may say, kal se hua hai, kal se nahi, this is more than this thing which they have missed upon. And regarding the general measures we have talked, the chemical sphincterotomy agent, now 80 to 90% of your patient of fissure in NO will heal completely with chemical sphincterotomy agent, especially with nifedipine or diltiazem cream. You need to use twice a day for at least 4 to 6 weeks. Those with recur again and again, or those who do not respond, those are the patients who will require surgery. And surgery, like you can use a sphincterotomy, internal sphincterotomy. Most surgeons are doing anal dilatation, which is not to be done nowadays. It is absolute and should be condemned, because that causes a lot of incontinence, especially the minor incontinence, which we never ask the patient whether there is any urgency or when there is loose stool or control of flatus. So internal sphincterotomy, we divide the sphincter at one point in a closed manner, is the treatment of choice. You can do it in open or you can do it with laser also. And this is what is to be condemned. So thank you for your patience hearing, friend. Thank you, chairperson, for giving me that extra time. And thank you, colleague, for patience hearing and not disturbing me while talking so much. Thank you.
Thank you, Dr. Niranjan. We are proud to have Dr. Niranjan in Mira-Bhayandar. He is president of Mumbai Surgical Society. Then he's secretary of ASI, also trustee of AMC Mumbai, so with vast experience as a good general surgeon, senior general surgeon also. So hats off to him and a big round of applause for him. Thank you, sir.
I would like to call Dr. Rajesh Korodia sir to chair this session. Korodia sir, please come on stage. We'll move on to the next session. This is by Dr. Mahesh Prasad. He's a nephrologist. Yes, sir? Yeah. Dr. Mahesh Prasad is a nephrologist and transplant physician in PD Hinduja Hospital, Mahim. He's also the teaching faculty for DNB in Hinduja Hospital and medicine in ML Dhole Hospital. He is awarded with the Rekha Memorial Tanker Award for Indian Society of Nephrology and was appreciated by Governor Appreciation Award for Dialysis. He is active member of many national and international societies, and many paper oration has been presented by him. His key interest in kidney transplant and renal. Over to Dr. Mahesh Prasad.
Thank you. My presentation. How will it change?
Felicitation for the chairperson. Dr. Agarwal sir, SN Agarwal sir, please come over.
Tea coffee is also served at the other end. You can take your tea coffee and come back and listen to the lectures.